everyone. I'm Dr. Alexis LaPietra. I'm an emergency medicine, pain management, and addiction medicine physician. I practice in Northern New Jersey, and I currently serve as the System Director for Addiction Medicine, as well as the Medical Director for Institute for Prevention and Recovery at RWJ-Barnabas Health. I want to talk to you today about opioid use disorder, which is a treatable medical condition. To start off, to frame how we currently treat a lot of our chronic medical diseases, I'm going to kind of go through a case with you. When someone does not feel well at home, they suspect something's wrong, we see them in the hospital. They come to the ED, we do our evaluation. Sometimes they need to stay, need additional testing, but we typically, whenever they're ready to go home, we give them medications, we give them support, we give them what they need so that they are not coming back to the ED and not coming back to the hospital. So sometimes we catch chronic medical diseases in the ED in the hospital, but we want to make sure that that person can go outside and really be productive and live a good life. When we think about opioid use disorder, we don't treat these folks the same way, but opioid use disorder is a treatable chronic medical condition, just like hypertension and diabetes, diseases which we might discover are causing major issues when folks come into the ED. So if we treat chronic medical disease in a fashion of support and providing medications and referral, what are we doing for opioid use disorder? We tend to see them. Maybe they stay in the hospital. Maybe we discharge them from the ER. We see them again. We see them again. This population has a lot of overlap with the healthcare system, but the mortality is so high. These people end up dead after, again, multiple interactions with the healthcare system, and they have a chronic medical problem. We know that the mortality in this population, when folks receive naloxone for a non-fatal overdose, is very high. We've been trending this data for years, and it remains around 7.5% mortality at 1 year when someone receives naloxone. That's a very, very high mortality for a human being who is in the medical setting that we send out. We would never send out someone who has chest pain or abdominal pain if we knew that they had a 7.5% chance of dying. And folks who we see for naloxone reversal, a percentage of them die within just 3 days of engagement with the healthcare system. So what can we do? Well, we can talk about medications for addiction treatment or medications for opioid use disorder with that patient. And of course, we need to be familiar with the medication ourselves. If you take someone who has a very, very high mortality for opioid use disorder, and you start them on medications for opioid use disorder like buprenorphine and methadone, you take that massive mortality and bring it down almost to that of the general population. And this is what we, again, do with people who come in with new onset chronic medical disease, someone who comes in with a very high blood sugar. We know they have a pretty good mortality, and we don't want them to die. We say to them, you need to start this medication. You potentially need to start insulin. We want to drive that mortality down. So we provide the support and the medication to do that. When we look at some quality metrics that are evidence-based that we do every single day in our practice, we appreciate a little bit the discrepancy between chronic medical disease and OUD. So I'm going to point some of these out. When we think about stroke or CVA, everyone gets antiplatelets. Why? The number needed to treat, so based on the evidence, the number of people we need to treat with antiplatelets to have one good outcome is 40. 40 people get antiplatelets for one to have a good outcome. For ST elevation, MI, or heart attack, everyone gets aspirin. 42 people need to get aspirin for one prevention of another heart attack. And then for steroids and asthma exacerbation, almost everyone gets either Solumedrol or prednisone or whatever steroid they get. 9 people need to get this for one good outcome. So this is what we do every single day. When you look at the number needed to treat for buprenorphine, it is 2. So that means for every 2 human beings you give buprenorphine, 1 will have a better outcome. So when we think of all of the medications that we give in the ED, in the acute care setting, just reflexively based on quality, based on evidence, it's troubling that we are not doing more buprenorphine, again, because of the evidence to support the massive mortality reduction in this population. I think we know the reason that we don't do this in medicine right now is really we were not educated. There's still immense stigma about the origins of the pathophysiology of this disease. So we have to own educating ourselves and really understanding what's going on from a medical point of view in this population. So to talk a little bit about the neurobiology, which helps frame why this is a medical problem and why medical professionals need to be addressing it, I want to start off talking about what opioids do. The majority of the population, when they have an opioid on board, they do have a sense of euphoria. There's a lot of dopamine that's released. And certainly there's a part of the population that feels really awful when they take opioids. They're very nauseous. They feel very sedated. They don't like that feeling. But for the majority of people, when an opioid hits their mu receptor, there's significant euphoria. So oftentimes we think this person with opioid use disorder is using because they're getting high or because they want that euphoria. But what we know is that is not true. In the beginning, they may feel some euphoria, but oftentimes they want to stop. They're not having fun, but they are still compulsively using, despite them saying to themselves, I don't want to do this today. I'm not going to do this today. A lot of folks want to stop, but they can't stop. And this was always a question in addiction. Why, if it's causing harm, this use disorder, why can't they stop? And we didn't have a good idea. And that is part of the myth that folks who have use disorder have a moral failing or a lack of willpower. But that's just not true. What we know now is there is an immense amount of neurobiological stuff going on with opioid use disorder. When the brain sees repeated, prolonged exposure to opioids, a transcription factor turns on. And that transcription factor is delta phosphate splice variant. This transcription factor gets into the entire brain and disrupts all of the neural pathways that are currently working really well. And it starts to change behavior and really, really change the interaction between a lot of the key parts of our brain when we're trying to make decisions. We also know that it's no longer dopamine driven. So no longer do we have this pleasurable hormone being released, this dopamine being released when we use opioids. After prolonged use, it's really glutaminergic. So glutamate becomes the neurotransmitter involved. And we know there are some links to compulsive behavior and glutamate. So now we're really understanding neurobiologically, this is not pleasure. This is not dopamine seeking. This is compulsive. This is neural circuitry change, and this is glutamate. So to explain that a little bit more, we're going to talk about a couple different centers of the brain. So the limbic system, which is our primitive pleasure-seeking part of our brain. We're going to use a horse in this example. This has evolved, and this plays a role in our survival related to pleasure. For example, we have to feel like we're with our tribe and we're with our community, right? We have to be safe within our community, and that spikes dopamine. When you see your friends and your family and you feel like you're part, you belong, that spikes dopamine, important for survival. Intimacy, procreation, that's important for survival. That spikes dopamine. And then things like food, that spikes dopamine. So we're driven on a survival, more of a survival basis, to seek things out that spike dopamine. However, we have a prefrontal cortex that's our executive functioning area. And we would all say that we've, evolved into pretty executive creatures. So we have the connection between the primitive center, which is definitely pleasure driven, but this executive center that kind of helps us negotiate whether or not we're going to be running around and trying to get food or be with our tribe or have sex. And then we have this braking system, which is the anterior cingulate gyrus. That helps us put a brake on the motor, and that helps us decide what are we actually going to execute. So this idea that we have, are we going to get up? Are we going to run around? Are we going to execute this in a motor activity? And all of this goes on every day, all day long, to stop actions or to promote actions. In the brain of a use disorder patient, this kind of switches. The limbic system is really where a lot of the neural circuits are coming and going. It has a lot more feedback and a lot more say. The prefrontal cortex, or the executive functioning area, is not as involved. There is not significant neural circuitry going there anymore. We are not interacting with our prefrontal cortex like we were before use. It's kind of this weak connection. And the anterior cingulate gyrus, or our brakes for the motor activity, are not there also. Those neural circuitries are very, very weak. So what we have is really this response based on what the limbic system wants us to do. And it's viewing, of course, opioid use as this pleasurable activity, and it's seeking out at all costs motor function to get to using that substance. And this is something we can empathize with. We can empathize with kind of falling off the horse, or not keeping our executive self connected to this primal self. When we do things, we can, we sometimes act, and then we look around and say, oh my goodness, I acted out of anger, or I wasn't in my right mind. I was so upset I couldn't think straight. This is when this executive center is not really attached to the horse, and the horse is just galloping along. But most folks are able to get back on the horse, engage that prefrontal cortex, stop what you're doing, and kind of recover. In a use disorder brain, this does not happen. This kind of recognition, this getting the rider back on, that is very difficult to do and very difficult to sustain. And that is all based on the neural circuitry. Another issue that we see with opioids specifically is the way they interact in the brainstem in a spot called the locus ceruleus. This is an area where we have our fight or flight button. And when we ingest opioids, we inactivate this area of the brain. We inactivate fight or flight. You're very calm, you're not very alarmed, you're not very jumpy. And this is the way that the brain is. That's where opioids bind, and they just inactivate. So when the fight or flight button is chronically inactivated from prolonged opioid exposure, when you actually remove the opioids, then the brainstem goes crazy. The fight or flight button is on, it is raging, and it's really driving that person to do anything they have to do to get that drug. It is life or death. It is crossing that busy highway. It is leaving your child potentially, losing your job, losing your stable housing. So all of these things that are harmful that we know happen with use disorder, this drive to use and abandoning everything else comes from this place of, life or death, fight or flight, and it has to do with the brainstem in the locus ceruleus. And the last part of the neurobiology that kind of brings us all together would be the medial orbital frontal cortex. This is our area for social connection. So this is what I talked about earlier. When you see your family, upcoming holidays, you feel so good, or you see your group, your people that just make you feel like you belong. This lights up the medial orbital frontal cortex. However, in people who have use disorder, no longer is the connection from, our people to the dopamine. Now, the thing that spikes our pleasure and the thing that makes us feel like we belong is when we see the drug. So now, and there's a lot of shame in here, as you can imagine, no longer seeing your parents, your brother, your sister, your partner, that's not making you feel like you are a part of something anymore. It is only when you see that drug that you feel like you have found your community. And that, again, a lot of isolation, a lot of shame, and it's so stigmatizing. But this, again, is neurobiological in origin. So when we say, just stop using, or, muscle through, this is a very unrealistic, unethical way to view recovery. These folks have a neurobiological issue, and yes, detoxification, where they no longer have physiologic withdrawal, is very important. That's a part of recovery. But that is a tiny, tiny, tiny little piece of recovery. It's as if we said, oh, you have terribly high blood sugar, come into the hospital for a couple days. We'll get the blood sugar down with insulin. And then we say, now go home, make perfect diet choices, and go to the gym 5 days a week. How many folks would do that? They had 5 days of detox. Their blood sugar was normal when they went home. Why are they not then engaging in all of the activities that make sure that they are perfect in their disease recovery? It's because it's impossible, and we're all humans, but we do give patients with diabetes medication. We absolutely do, whether or not they go to the gym, whether or not they make any diet changes. So we have to remember that these folks have a medical disease and we need to treat it like the other medical diseases and really be supportive when we send them home. There's so much suffering that goes on in early recovery and in recovery in general that we need to make sure that we are keeping our community safe. And in the age of fentanyl, which is very, very potent, if people are abstinent from opioids for a period of time in their recovery, have no support with medications for opioid use disorder, and have a bad day like we all do and relapse, that potency will lead to their death. So as a harm reduction strategy in early recovery as well, medications for opioid use disorder can be very helpful. And they deal with this craving, this life or death craving, that's all neurobiologic. So the brain has the power to heal, which is miraculous. And we know that from patients who have traumatic brain injury and patients who have stroke, but we know it's not quick. We know that this takes a long time. So knowing that about the brain, we need to give folks grace and we need to give them a nice long runway where they are recovering. It is not 5 days. To use another analogy, if we said, oh, you fell off your bike and you have a broken bone, okay, it will take 6 to 8 weeks to heal. So just don't ride your bike. We would say, well, wait a minute, I'm going to be in so much pain. And we'd say, well, stop riding your bike. Just say no to your bike and your body will heal. Yeah, but it's going to take 6 to 8 weeks. I'm going to suffer. I'm going to have pain. Well, I don't know what to tell you. Just say no and don't get back on that bike and you'll be fine. We would say no. That is unacceptable. I am not going to be in my life roaming around with a broken femur, despite the fact that if I just give it 6 weeks, it will heal. We would say, can I please have crutches? Can I please have something that helps reduce harm? Because I'm going to have to get around, and reduce suffering because it hurts while I'm healing. That is what we would ask for. That was what we would expect from the medical community. And that is what we are asking for medications for opioid use disorder. We are asking that we support and protect our community while they are recovering. So there are many ways that we can use. I'm going to talk specifically now about buprenorphine. Buprenorphine is a medication for opioid use disorder, FDA approved for people who are 16 and over. There are a couple different formulations, and this can be a little bit confusing. The brand name Suboxone is pretty widely recognized. That Suboxone has 2 different medications. It has buprenorphine, the medication that binds to the opioid receptor and helps that person reducing cravings, helping them feel better. The naloxone component of buprenorphine was added as an abuse deterrent, so that if folks decided to inject buprenorphine naloxone, they would go into withdrawal. So the naloxone is only put in as an abuse deterrent. Naloxone is not absorbed sublingually, which is how you take Suboxone. When you put the film or tab under your tongue, the buprenorphine is absorbed, not the naloxone. The naloxone has nothing to do with it. But naloxone as an abuse deterrent for buprenorphine is interesting, as we have no other naloxone abuse deterrent tablets when we think about other opioids, such as OxyContin, oxycodone, morphine, and hydromorphone. So naloxone added to this. Interesting, but doesn't get absorbed. The other preparation is just monoproduct buprenorphine, and that comes as a tablet. So if you are looking to give a patient a film, which does dissolve a little bit quicker, is a little bit easier to take, then you would really want to opt for the buprenorphine and naloxone product. You can also get buprenorphine and naloxone in a tablet, but that film is only available in the combination. And for pregnancy, we have now, we know that you can take film with naloxone or a tablet. So no longer are we leaning on Subutex, that mono product in pregnancy. It's really up to the patient what works best for them, film or tablet. Sublocade is relatively new, and this is a long-acting injectable buprenorphine. This is FDA approved for people who have opioid use disorder and who have been on buprenorphine around 16 to 24 milligrams for at least 7 days. And this, of course, improves compliance. It's easier. You don't have to take something every day. In early recovery, this may be easier for folks. And we know for many medical conditions, long-acting injectables are easier. So if it's an option for a patient, we do have it available. And let's talk a little bit now about how buprenorphine works in the brain, because it's a pretty incredible medication. So this partial agonism, the buprenorphine binds to the mu-opioid receptor. Mu-opioid receptor also has oxycodone, morphine, dilaudid, heroin, that fentanyl, it all binds there. When buprenorphine binds, it only activates 50% of the receptor cascade. A full agonist, oxycodone, fentanyl, heroin, is 100% activation. So when you have 100% activation of the mu receptor, as you keep adding opioids to the brain, you are at risk for shutting down your respirations completely. And that, of course, is why opioids are fatal. The partial agonism, that is not the case. So for buprenorphine, you have a ceiling effect, meaning you can't have a dose-dependent apnea. The respiratory rate is cut in half. So it'll be cut by 50% at maximum, but it will not come down to zero. When you have alcohol, benzodiazepines, or other CNS suppressing medications on board, then it is not true. I mean, co-ingestion is a big problem with respiratory depression, but as a single agent, the partial agonism has a respiratory ceiling. Now, this high affinity is another pretty cool aspect of buprenorphine, and it's somewhat protective. Once the buprenorphine is on the receptor, or even as it's going by the receptor, it'll knock off any other opioid that's there, and it's going to lock in. It's not coming off. So it locks in. That's awesome. It can't be displaced by their opioids. So even if people use, really none of that opioid is binding, and then it's only activating 50%. So when you think about some of the concerns related to buprenorphine, a big one is buprenorphine precipitated withdrawal. And that is when buprenorphine is ingested while there are still opioids around in the brain. So the buprenorphine comes by and knocks off whatever is there, doesn't move from the receptor, but it only activates 50%, as opposed to the 100% activation the brain was seeing earlier. The other benefit is a slow activation and a slow elimination. That means once it's on, we have at least 24 hours before it metabolizes off, which is nice. Therefore, the dosing does not have to be as frequent when we're managing opioid use disorder. To give you maybe a little bit more of a picture to explain the high affinity partial agonism and how this relates to withdrawal, if your brain is seeing this massive, Niagara Falls, this massive waterfall all the time, 100% activation, and buprenorphine comes along and flicks off that opioid, it turns the receptor down to 50%. So the brain perceives that as a withdrawal. I was just getting 100%, and now I'm immediately getting 50. And that's why folks have symptoms of withdrawal when you take buprenorphine too soon. So not that challenging, but people need to be educated. Physicians, providers, clinicians need to be educated, because there's a way that we can do this safely and that patients can get started on buprenorphine, avoiding the withdrawal. The traditional approach is to use the clinical opioid withdrawal scale. And it's not a perfect scale, but it is pretty good. We want to do this at bedside with the patient. Some of it is subjective and some of it is objective. So we want to focus on objective signs of withdrawal when we're getting ready to dose the patient. You can get to a pretty good COWS with just subjective symptoms. But in order to really know and feel confident that that person can safely start, we want to see some objective symptoms. And to throw a little wrench in this, heroin had a quicker half-life. It really metabolized out of the body within around 12 hours or so, and we didn't see a lot of precipitated withdrawal. Now that we have illicit fentanyl, which is the majority of illicit opioids, definitely nationally, if it's not in your area, it's probably coming, but the illicit fentanyl deposits in the fatty tissues of the body, and when you use it every single day, it becomes long-acting. So what we see is folks do not have signs of withdrawal for 24, 48, sometimes 72 hours after last use. So this makes us really pay attention to the COWS and talk to the patient. We want to know, when did you last use? Because I want to make sure we can start you on this safely. And this is frustrating. It's frustrating because if you were comfortable doing this before, this is a change. And if you're not comfortable, we really have to pay attention, but it's not an excuse. just have to talk to our patients and really make a patient-centered decision. If folks come in to the emergency department or they're in the hospital, this is a very simple conversation. I want to help you. I want you to stay. I want you to complete treatment. I want you to be safe. So we can start buprenorphine or Suboxone, but I have to ask you a few questions. I just want to know, when did you last use? This will help me understand better when we can go ahead and start. If that person is not in withdrawal enough that you feel comfortable starting, the conversation is, I can't start the Suboxone right now, but I'm going to give you the prescription. You can start this out at home, and I'm going to give you some medication so that while you're waiting, while the body is processing the opioid, you feel okay and you have some support. So you give them the prescriptions they need for symptomatic management alongside the prescription for buprenorphine. And there's a whole host, and there can be different protocols based on your hospital, based on your state, based on guidelines. This is just one example of what you could use to help people feel a little bit better. And this is, again, all about harm reduction. We have to give prescriptions, even if we're not sure that the patient will follow up, or we're not able to make sure that you got that appointment for the patient. Because if that person is on buprenorphine, even for a couple days, that means for those couple days, it'll be less likely that they're going to die. And it can show the patients the empathy and the support that the healthcare system is providing them. Because we all know, typically speaking, we have not been so kind to this population when they come into our hospitals. We want to plant seeds of empathy, and we want to show this population that we are here to help them, because we should be here to help them. So we don't have to be punitive and say, if you're not going to be perfect and you're not going to get to that appointment, I can't give you a medication. No, wherever you land, you get this medication because you deserve good quality, evidence-based care, and that is what this prescription is. We also hear often, oh, I don't think that they're going to use it. They'll probably just sell it. No one is pro-diversion. We want people to take the medications prescribed to them. But when we look at this from a population health point of view, the diverted buprenorphine is purchased by people who are looking to use it for withdrawal symptoms. And there have been lots of studies evaluating diverted buprenorphine and where it goes. And this is what we've determined. This is what we see. So people can't get buprenorphine in a healthcare setting. They can't get in to see a provider to get their script. So they are buying it. It's pretty expensive. And they're buying it off the street to treat themselves. So again, not pro-diversion, but this is not a medication that tends to have a strong abuse population. It is used for its intended purpose. Lastly, we need to give naloxone kits to all of these folks. Absolutely 100% anybody who's received naloxone and was naloxone reversed. But in general, we need to have a blanket of naloxone in our community. We need to empower bystanders from everywhere to go ahead and get in there and help if they see an overdose. It's the same thing we have been talking about with CPR or AEDs. If someone goes down, the community needs to come in, assess what's going on, and understand how they can hopefully bridge that patient to the ambulance getting there, either with CPR, potentially with naloxone. So carrying naloxone all the time is great. And also we want to ask our hospitals, our offices, our community to show us where that peer support is, to show us where the social support, case management, we need to help the population with any of their issues, social determinants of health, stable housing, employment. We need to be there to really support this person in their recovery. So that means the medicine for sure, but it also means peer support or some wraparound services. So I hope today that I was able to convince you a little bit that opioid use disorder is a treatable medical condition. Irrefutable, cannot argue that we need to recognize this and we need to treat this in our healthcare settings. These folks, when we see them, when you look at them, you need to appreciate that there's a good chance that person will die. And that is the sickest person you're going to see that day. If they are using and they've received naloxone, we really need to capture them during that encounter to give them the support they need. We have to view the population again as sick, and we have to appreciate that anytime we see a patient, even if it's not related to naloxone, if it's just related to either cellulitis, urinary tract infection, laceration, abscess, whenever the population presents. It's just another opportunity to be empathetic and engage them, to support them that the healthcare system is there and we have things that we can do to help them. And lastly, the home induction is a way that we can do this if we cannot utilize buprenorphine in the acute care setting. If they're just not ready, if they're not in withdrawal, we need to appreciate that prescription and home induction instructions are what we need to do. So we need to do it in the hospital for sure if they're in withdrawal, but if they're not, it doesn't mean we offer them nothing. It means we offer them, again, a script, instructions, and support. And I'll end with this. A lot of us did not train understanding what substance use disorder was. We do not understand the neurobiology. We did not understand the medications that we can use. That's no longer an excuse. Now we know how we can do better. Therefore, we must do better. The death toll is rising, and we need to really make sure that we get on top of this population anytime they cross our paths. So I appreciate your attention to this today, and I hope you found it helpful. Thanks.